I welcome you today to this special session that we're going to be hearing from Dr. Jamie Stutz. What's super special about today is this is a joint presentation of the annual meeting of the Colorado Cancer Coalition and the Learning Collaborative on Lung Cancer Screening that we developed here in Colorado. And so we're happy to be able to have expanded our audience today to those folks through the Colorado Cancer Coalition and also through the pretty large network of participants that have been participating in the webinar series that's been ongoing for the Colorado Learning Collaborative. So thank you all for joining us today. And just a little bit of housekeeping. If you are part of the Learning Collaborative and you're wanting to have, or if you're participating through the Cancer Coalition, you can get CME credit or nursing credit for this hour of presentation. And also, the session has been approved for one COPIC point. And particularly for those folks that are going to be requesting the COPIC point, if you could put in the chat box your name and your profession so that we can be sure that you are accredited with the COPIC point. And for those outside of Colorado, this is the Colorado Professional Insurance Corporation. So we are just so thrilled today to be able to have Dr. Jamie Stutz present to us. Jamie is a professor of medical oncology at the University of Colorado School of Medicine, and he's the scientific director of behavioral oncology. Prior to joining the University of Colorado, Jamie was at the University of Kentucky and a professor of behavioral sciences there. Dr. Stutz is a licensed clinical health psychologist, and his research interests include the behavioral aspects of tobacco-related malignancies, shared decision-making, behavioral change regarding prevention, screening, and survivorship. And he has been recognized certainly by many of us, and some of us have had the good fortune of meeting Jamie in the past through the National Lung Cancer Roundtable, where he has been a huge advocate and very well informed about lung cancer stigma. And we know that he is going to have many good things to share with us today that we need to hear about related to lung cancer screening. And in addition, lung cancer stigma, lung cancer screening, and then reaching our rural communities for lung cancer screening. So Jamie, I welcome you and we look forward to hearing from you. Thanks.
Thanks, Debbie. I really appreciate it. And I'm just really excited about being here in Colorado. You know, family-wise, the opportunity here is just tremendous, and I can't imagine any other place where I'd rather be stranded in a pandemic. But I appreciate the opportunity to talk with everyone here about lung cancer stigma, as well as some of our work, most of it in Kentucky so far, to reach rural communities with some of our lung cancer screening programming. I don't have any conflicts of interest to report at this time, but I want to be 100% clear that, you know, in terms of talking about lung cancer stigma, I do not claim to be immune in any way to how this, you know, devastating issue weaves its way into how we work and think and act in regards to comprehensive lung cancer prevention and control. In some ways, it can be quite subtle. In some ways, it can be quite overt. But I fully believe that even the people who, you know, do work on this full time still have areas where we can reflect and think and do things in a more effective way and non-stigmatizing manner. But I do, like I said, try to maintain a vigilance to confront my own biases and stigma when I become aware of them. I know I have blind spots and issues where I think in unproductive ways toward helping people achieve better lung cancer care, and it's just a process. So lung cancer control continuum is seeing tremendous innovation across the entire spectrum. We have broader efforts about policy efforts related to access to tobacco treatment. Radon is growing in awareness in terms of its impact. Of course, many of us are thinking a lot about early detection strategies with low-dose CT and implementing that across the country. Diagnostic tools are more available, and very innovative things are happening in terms of treatments, and whether it's surgeries, radiation therapies, or our immunotherapies and targeted therapies. And even in the space of survivorship, in terms of palliative care interventions, Jennifer Temmel's work at Mass General showing that aggressive palliative care can not only improve quality of life, but quantity of life among individuals diagnosed with late-stage lung cancers. And this is a time when lung cancer is leading the way in oncology. There is innovation and optimism and hope that's being infused at every single level across the cancer control continuum. And so it's a great time to be really transformative in lung cancer care. But unfortunately, there is a cloud that I think that kind of hovers above us and impairs our ability to really optimize the delivery and outcomes of all of this innovation. It is, of course, lung cancer stigma, and that tends to impair our ability to deliver these evidence-based interventions with regard to tobacco and radon. It hampers our ability to reach our communities and manage the early detection lung cancer screening programs. Many people in our rural areas are not getting the optimal diagnostic strategies and biomarker testing that's helped guiding our treatment efforts. We don't have enough access, and some of the financial considerations related to some of our novel treatments are causing barriers to optimal outcomes. And then finally, there's very minimal uptake of survivorship care, palliative care interventions, particularly in the lung cancer space, where there hasn't been a tremendous amount of work. And to some extent, I understand the justification for that. But now, with the optimism that's being infused across this entire care space, we really need to be thinking about quality of life and well-being much sooner in the process to make sure that we're optimizing outcomes, because we do have an infusion of hope that is extending lives and improving quality of life for individuals who face a diagnosis. So today I'm going to talk a lot about lung cancer stigma, hoping to stimulate some reflection and thinking about how it impacts the work that you do and that we do in trying to achieve optimal lung cancer prevention control. But then I'll transition to talking about some of our community-based and person-centered strategies that we've used to increase access to lung cancer screening in Kentucky and make it relevant to Colorado and hopefully a national audience as well. So I want to start into talking a little bit more specifically about lung cancer stigma. And when you look at these two individuals, which one of these individuals deserves more empathy and compassion following a diagnosis of lung cancer? Well, of course, they don't. Neither one should experience a difference in how our society and our community and our clinicians and our family members provide support and empathy. But following up with that question, which one do you think receives more empathy and support? And of course, it is the person on the left. We have hordes of data showing that if diagnosed with lung cancer, individuals who are using tobacco receive less support and have fewer opportunities to optimize their care. And I tell the story for just a little bit of background because I grew up with substantial lung cancer and tobacco-related stigma in my life. This is my grandmother who has passed away at the age of 96. Her first husband died in just about a year older than I am right now with a tobacco-related illness. Is of cardiovascular nature. But as you might expect, she developed a great a negative predisposition toward tobacco use because her husband and my grandfather was a heavy pipe and cigarette smoker. Matter of fact, I go back to pictures of my childhood, and there is never a picture of me and my grandfather without him having a cigarette or pipe in his hand. But after his passing, she became a pretty strong advocate against tobacco use. In fact, she had a secret weapon that she carried around with her. And when individual was having to use tobacco or smoke around her, she would pull this out and blow the cigarette or tobacco smoke back in their face. And as a kid, I thought, my goodness, my grandma's got spunk. And I really appreciated that about her. But that's also how I grew up thinking about people who used tobacco. And it took me quite some time to come around to the idea of thinking about individuals differently and how I interacted with them as a clinician, but also as a researcher. So what is stigma? At its most fundamental level, it is a mark of shame or discredit. Other folks would think of it as a disgrace associated with a particular characteristic of an individual. And Goffman is highlighted in sort of the nerdy academic definition is an attribute that is deeply discrediting, that turns an individual from a whole and usual person into a tainted and discounted one. But most specifically, and I think the easiest way to think about it is a process of othering, of distancing, of separating between yourself and someone else based on a specific characteristic. And of course, this is not just limited to lung cancer or tobacco use, but nonetheless, it is something that I think pervades our society as well as our clinical settings, and we'll talk about that in a little bit as well. My colleague, Dr. Heidi Heyman, has really helped put together a conceptualization of different aspects of health stigma, and particularly lung cancer stigma. And just to get a little bit of groundwork on this, perceived stigma is a recognition of negative appraisal and devaluation from others. And that is to the extent what we recognize in society and when we interact with people. Then there's enacted stigma or felt stigma. These are overt acts of discrimination from others that you can see and observe and also can be referred to as bias. Then we have a very toxic and important one that we have to consider as well that's sometimes left off, and that's the internalized stigma or self-blame of how people believe in terms of their own histories and think about themselves. And it can also impair, those of you who've worked in lung cancer have probably heard, I really don't deserve that based on this X and Y in terms of optimal care or support. And it's really heartbreaking when you can hear people actually say that and have such a strong sense of self-blame in our context. And that leads to one that I like to add in as an outcome in many ways of stigma, and that's constrained disclosure. You see this in so many different ways that people are reluctant to acknowledge they are either at risk for lung cancer due to a history of tobacco use or other factors, as well as a hesitancy to acknowledge that they've been diagnosed with lung cancer. Women will commonly report to me that they've kind of pawned off their diagnosis on breast cancer and claim to have that as opposed to the lung cancer that they actually are experiencing. And it's a real shame that people have that internally and that sense externally that they can't be honest and open and expect to receive the same support and compassion that they would expect if they had another diagnosis. I think perhaps one of the greatest examples of this, if you talk to anyone who has been diagnosed with lung cancer, that this is inevitably the most common question that they receive following acknowledgement or disclosure of a diagnosis, something to the effect of, "Did you smoke?" And my thinking of this has evolved over time, to one that initially started with what a what a disgusting statement to say at the first glance of someone, of learning of a diagnosis, that you immediately start with the othering process of, "Did you smoke?" and essentially, "Is this your fault? You should have known." There's so many other side messages that come in with a question like this. However, I've sort of transitioned to thinking of it, trying to think about it differently. And this is actually might be a failed attempt to affiliate. And what I mean by that is, this is just the one thing that people know about lung cancer. And that is sad in and of itself, that we haven't done enough of a job to understand, to help our society understand that there are many reasons to get lung cancer. And the one factor that's 100% correlated with having lung cancer is having lungs. And that really everyone is at some level of risk, and that isolating individuals who have smoked or have a history of smoking can help us in some ways identify strategies to mitigate that, but in general it does not help us by isolating and othering them and alienating them from anything that could be helpful in terms of improving their outcomes. There's been a tremendous amount of work over the past decade in terms of documenting the presence of lung cancer stigma in its various ways. And Dr. Joan Schiller, in collaboration with many others, has developed the Lung Cancer Project, which is a way of understanding lung cancer society's perspectives and clinical perspectives on individuals who are at risk or have been diagnosed, using strategies that of implicit bias and how people associate various terminologies and perspectives with lung cancer. And you can see that Joan was able to show that 67% of people associate shame with the diagnosis of lung cancer. 74% have experience a stigma in the way that they interact. And they associate lung cancer, 75%, with stigma's kind of sibling of nihilism and fatalism and hopelessness, that a full 75% of the community thinks about lung cancer in a very hopeless way. And this is an example from Kentucky that really gets under my skin a great deal. And this is sort of an example of even sometimes well-meaning people get it wrong. This is a slide that was presented to the Cabinet for Health and Human Services in Frankfort, Kentucky, in the legislature, and simply stating that the lung cancer had received about $10 million in the tobacco settlement dollars to fund research. And this person was advocating for more pediatric cancer research, which is obviously not a bad thing, but was taking the angle that this money is not deserved by lung cancer, but rather should be reserved for the kids. And I think this highlights what an acceptable target society believes for lung cancer research. Never mind that those dollars were generated based on the tobacco industry manipulation of tobacco and not recognizing the burden that it caused, but that it would be somehow acceptable to raid those funds and use them for other purposes rather than to directly help the people that it harmed. The GO2 Foundation, formerly the Lung Cancer Alliance, has also been a pioneer in understanding the burden of lung cancer stigma among patients, the toll that it takes on them, as well as the clinical ramifications of some of these things. And they've done a couple of studies over 10 years. They administered a survey in 2008 and another time in 2018 to look at the data to see if there are trends in how society and how clinicians think about lung cancer stigma. And you can see that unfortunately from some of these, many of these things show actually an increase in lung cancer stigma over a period of a decade. Now, one negative way to interpret that is, oh, it's getting worse and worse. However, I choose to think about it a little bit differently. I actually think of lung cancer stigma as virtually ubiquitous, and it's 100%. And these actual shown increases over that decade are actually an acknowledgement and acceptance that it's actually happening, and an awareness of it, and actually provides a little bit more of a footprint for us going forward. And I think much of this is actual underreporting of things that have happened to people. Another example of more of an enacted stigma is this old data from the National Lung Cancer Partnership, now evolved into a different organization. But you can see here in this, what this slide is meaning to depict is that the total burden in terms of lung cancer deaths in the blue there is overwhelming. It's if you combine colorectal, breast, and prostate together, not as many people die each year in the United States of those three cancers as die of lung cancer. However, the dollar signs equate to the amount of federal research funding that's allocated. And you can see here that there is barely $1,450 of research essentially that's allocated to on that metric per death. And this is one of the things where it's shocking, it's appalling that this little research dollars are dedicated to such a devastatingly impactful cancer. Another example comes from actually the Department of Defense funding, and I've made this one myself. The Department of Defense has a research program, or cancer research program, and here's the incidence of melanoma, for example, and as well as the incidence of lung cancer in last year. And that lung cancer has 2.25 times the incidence of melanoma. And it has, 35.25 times the volume of regrettable mortality as melanoma. And yet, when you look at the Department of Defense research funding, actually, melanoma receives 25% more research dollars than does lung cancer. How is this an acceptable scenario if if lung cancer stigma didn't exist? And of course, lung cancer stigma does exist, and I think that this is a prime example. So those are some big picture examples. But what about in the clinical settings? We have data that shows that 50% of individuals diagnosed with lung cancer feel stigmatized in some way by their oncologist. And this can come out from in a variety of ways. A lot of it can be tied to how a clinician talks with an individual about their tobacco use history, and whether it's a supportive way or an unsupportive way. We've done some research in trainees, medical students, and nurses to help design programs to help them think about risk of lung cancer in different ways. And we did a study of our participants, and what we did is gave them a little vignette and asked them, how do you think about this particular patient? And half of them were randomly assigned to receive someone who'd been diagnosed with lung cancer. Half of them received a person who'd been diagnosed with colorectal cancer. And within that, we also embedded half of the people had a tobacco use history, and half the people had no tobacco use history. And then we asked them a series of questions about how they felt about that individual, to elicit in a different way and comparative way about potential sources of lung cancer stigma. And we found these results. Essentially, when an individual was diagnosed with lung cancer and had higher and no use of tobacco, those students reported higher ratings of pity. And essentially, if you think about that, basically what they're doing in that scenario is saying that, boy, those folks really didn't deserve it, but they got stuck with that diagnosis. And it's another sort of societal manifestation of how we think about lung cancer diagnosis differently. In the same way with sympathy, there was a lot of sympathy portrayed or reported for those individuals who were diagnosed with lung cancer without a history of tobacco use. And in other areas, it was the actual the smoking history that mattered and not the diagnosis. That these clinicians in training reported greater aggravation for toward individuals who had a smoking history, greater anger. Now these are still low levels, but they are different. Indication of people thinking differently about this community than a non-smoking community. So I think one of the ways I'm trying to present this is to have a socio-ecological understanding of lung cancer stigma and how various levels of our society and interact and also experience lung cancer stigma. So at the individual level, there's a lot of self-blame and distress that is generated. We know that individuals diagnosed with lung cancer experience higher rates of not only stigma, but also the distress than many other individuals who are diagnosed with other cancers. Interpersonally, this causes a lot of blame and conflict in our families among individuals among families who are facing lung cancer, talking about failed efforts to quit smoking or differences in smoking behaviors among family members. At the organizational level, we see different patterns of care for individuals who have a smoking history than others, and disappointingly so. We also experience an isolation and disdain. I don't know if any of you have ever attended a lung cancer walk, but it's just a little bit smaller than a breast cancer walk or an organizational event. And there's a host of reasons for that. But one of them is that our society does not embrace individuals diagnosed with lung cancer in the same way we do individuals diagnosed with other cancers. And I've already showed you example of policy level differences, whether it's research funding or other domains where there's essentially what I think is a neglect or an indifference that is evident in how we see this community or individuals at risk. Where does this stigma come from? I think the high disease mortality that we've all experienced with this, that nihilism that is very common, the fear that accompanies that nihilism or a lung cancer diagnosis. There's a need to distance ourselves from this risk perception or belief that we are vulnerable to this devastating illness. And really, there's also a lack of survivor visibility in the community. We do have some very strong lung cancer advocates that are active in Colorado as well as nationally, but there's not as many of them. Certainly as other cancers. But unfortunately, what I think is one of the most common causes is, of course, the link to our aggressive tobacco control policies. And you can see the CDC campaign here, the TIPS campaign. And the funny thing is, for years, I thought that TIPS was an acronym that I didn't understand and was kind of embarrassed that I didn't understand, but it's not an acronym. It's just tips, like advice, like guidance, like a tip for smoking cessation. And you can see a picture of Terry, who has since passed away, but she was a very prominent figure in the TIPS campaign. And essentially what these were doing was to connect smoking with these various health outcomes, and for people who've experienced those health conditions to acknowledge that and to put their story out. And the TIPS campaign has been a very successful campaign. If you focus on efforts to drive up use of the 1-800-QUIT-NOW guideline, the telephone quit line, and on a population basis, there's an estimate that over 500,000 individuals who use tobacco have quit for good. But there's been virtually no attention to some of the downstream and negative side effects of the TIPS campaign. Nor has anyone asked, what does the TIPS campaign message do to an individual who has already experienced a tobacco-related illness? Does this make them feel warm and fuzzy and feel like they're supported? No, it's another way of isolating and really, I think, endangering them in terms of the support that they receive from family, clinicians, and society. Was empathy considered as part of these campaigns? And the answer is no, that this is not. They're solely focused on the goal. And the comparison I like to draw is with a cancer clinical trial. Would we ever do a cancer clinical trial and not bother to assess the side effects? Would we not bother to look at the long-term consequences, the late effects, the long-term and late effects of these treatments? Of course we wouldn't. We couldn't do that. FDA would laugh us out of the application process if we presented a new agent that was wildly effective and didn't present any information about adverse effects. It's just not possible. Well, unfortunately, that perspective is not integrated into our community messaging campaigns. And I want to throw out there the possibility that we do have the potential to do effective tobacco control using non-stigmatizing messages that demonstrate support for a community that is often stigmatized and isolated. Our efforts at youth tobacco prevention are similarly wrought with very complicated and intolerable messages if you look through the window of stigma and bias. A good friend of mine, Dina Cook, who is a lung cancer survivor and advocate, has shared these with me. These are examples of some of the tobacco prevention programming where the activity actually asks people to ask kids to draw pictures and make depictions of what it's like, or some of the harms of tobacco use, as well as some of the more broader messaging, the Canadian message, as well as an Australian one, depicting smoking as slow motion suicide. These are in many ways, helping to isolate in other individuals who use tobacco, and failure to understand the concept of nicotine as an addictive agent, that many people started smoking before they were making great decisions about their life in adolescence, or understanding long-term consequences. And yet we're putting all of the responsibility on the individual and virtually none of the responsibility on the tobacco industry for the manipulative products and marketing and messages that they have inflicted on society for decades. I don't really have too many strong feelings about that, but you can obviously hear those. So we've had our fill of talking about the problem now, or at least I have, and I think that the evidence showing that it impacts multiple levels of society is profound, and we really hardly need any more of that. And so as part of the National Lung Cancer Roundtable, we're in the process of developing a lung cancer stigma initiative that we hope will be a national initiative. And part of it is using this pathway that we've developed to understand the causal factors that are influencing the development of stigma across multiple levels, from individual through groups and societal levels, and to acknowledge the consequences of that. That's kind of been done, and what we need to do is take that next step to erase lung cancer stigma from our society at all of its levels, and in order to move things forward. But in order to do that, The long-term goal is to eliminate those causal factors, to change our society and culture and the way we think, the way our families interact, their tobacco messages in the media, and as well as the care we provide to individuals who are either at high risk. That is a long process. We're talking about societal change here, and that doesn't happen overnight. And I'm going to restrict any political references there. But while we do that and make those changes, we also have to be understanding and mitigating the consequences that are actually already in place. We have to work on ways to improve access to high quality tobacco treatment, to lung cancer screening, to better diagnosis and better treatment and survivorship interventions. And while it would be nice that if we could just eliminate everything and the problem would be solved, while we are in that process, we have to also work on mitigation efforts. And in some ways, this is the causal effort work is the long game, but our short game is to make sure that people don't continue to suffer the consequences of stigma while we work on achieving that long game outcome. So I'm going to spend a little bit of time now talking about some of the things that we can do as clinicians and public health people and advocates to change the lung cancer stigma equation. And the first thing that I point out to is self-reflection, and I acknowledged that at the beginning, that I think we have to spend some time reflecting on how we interact. And sometimes we do things with the right outcome in mind, but not necessarily the right process that gives us the best chance of achieving that. Do more things with empathy and compassion, and maintain vigilance over time in how we're interacting with this community and learning new ways. And then finally, prepare, to prepare for change and to work on a different way of interacting. So regardless of your role as a clinician, there are different ways to think about changing how we go about it, working with individuals who are either at risk or diagnosed. How do we think and feel when we interact with people who are using tobacco? I acknowledge that I have blind spots and continue to work on this. I have always struggled in my career with how to interact with individuals who are using tobacco in restricted areas. I have a photo library of individuals using tobacco, leaning against tobacco signs, tobacco restriction signs. And I've had a history of not always interacting with those individuals in the most productive way. But also, how do we interact with individuals diagnosed with other stigmatized conditions? We spend a little bit of time thinking about intersectional stigma. That means communities who have multiple layers of stigma, whether it be a racial, ethnic biases or other socioeconomic related biases, and how that interacts with our thoughts about them as a person who uses tobacco or suffering from a tobacco related illness. Another way to deal with countering stigma is preparation in anticipation. Particularly working with an individual who's been diagnosed with lung cancer, they are going to be asked, did you smoke? It's inevitable. No matter how well they know their community of folks, somebody is going to ask them that question. And are they prepared to deal with it? And there is no one way of dealing with it. There's only the best way that each person knows how. And instead of kind of waiting until you get that question and figuring out what to say, the Lung Cancer Alliance, or now GoTo Foundation, has generated some tools to help people to educate themselves and to think differently. Is the most comfortable strategy for you to not take it personally, to rise above the question, to use it as a platform to educate. Well, actually, the vast majority of individuals who are diagnosed with lung cancer aren't currently using tobacco, and even more our individuals are being diagnosed without a tobacco history. If we were to take non-tobacco related lung cancer out of the equation, it would still be the sixth highest cause of cancer death in the equation. So do you just ignore it, or do you want to get all psychological with them and just confront them and say, does it really matter at this point? So it's not about any particular strategy. It's about the process of finding a strategy that's comfortable for the individual to interact when they do get that message. We're also working on other stigma-free principles and guides for both the clinical community as well as more broadly. And one of the ideas is a lung cancer stigma biopsy. And that's developing a set of principles that we can use as a guide to review all of our lung cancer and tobacco-related marketing, messaging, patient education tools, websites, to go back and make sure that they are stigma-free and they're empathy infused and compassion is the message and support is the message, rather than anti kind of messages that can isolate and other. And then we're also working on, with the IASLC, what we're called a stigma-free lexicon. That's alternative terminology to removing stigma from your communications in other situations, whether they be clinical or non-clinical settings. And these are ongoing work that's happening now. Colleagues at the Memorial Sloan Kettering have also been pioneering work on training clinicians how to empathically communicate with individuals diagnosed with lung cancer, particularly around their tobacco use history, and how to ask about their tobacco use in ways that build a relationship and do not tend to isolate or differentiate those individuals. And so that's some very exciting work. But in reality, the most effective strategy that's been used to help overcome stigma and bias, and let's not go into the details here, but this is research done by psychologists in the 1950s of how to bring groups together. And many people have tried and many people have failed, but the data continues to come out that the most effective way is to be with the stigmatized community. For our advocates to feel more support, for them to be comfortable interacting in the community and challenging some of these biases and helping people think differently about lung cancer and differently about lung cancer survivors, in order to build a more compassionate and empathic society. Another strategy to support is reframing the conversation. The GoTo Foundation a few years ago put out these messages with regard to no one deserves to die. And if anybody wants to know the story about that, I know we have at least one GoTo Foundation staff member on the call. Robin might be able to tell us a little bit more, but this caused quite a hiccup in the various markets where it was implemented, and they had to change plans because people reacted so aggressively with regard to some of these messages. And then the next piece is the marketing and communication approaches. And this is where we can have partnerships with industry to share a different message about lung cancer. And both of these messages for these newer immunotherapy agents have the impact of normalizing the conversation about lung cancer. We probably know that Betty Ford was the first person to say the word breast cancer on national television just a few years ago. But until these messages, this may have been the first time when people really legitimately were exposed to messages about lung cancer on television that weren't either about tobacco cessation in some way or some other factors. And it also brings an opacity or a presence in our community of individuals who've been diagnosed and are survivors, or those community of individuals that are at risk. They exist, and we acknowledge and embrace them and try to find ways to support those efforts. And so one of the things that we're doing is the Lung Cancer Stigma Initiative, and trying to develop a strategy that can be national, that can be comprehensive for many of folks to embrace, whether it be our advocacy organization colleagues and through the American Cancer Society, GoTo, Longevity, Free to Breathe, and all, the host of organizations that are out there in support of lung cancer advocacy, but also institutions, and really helping them reflect on how they interact with this community and what they can do to optimize outcomes. So to draw this part of the talk to a conclusion about lung cancer stigma, it's a pervasive and destructive aspect of our culture and healthcare, and patently, lung cancer stigma kills. It doesn't kill directly, overtly, or in the dramatic manner, but it silences our ability to engage people with treatment, with screening and other strategies that ultimately is an indirect cause of earlier mortality. We have a lot of research, but we needed to turn the corner to develop interventions to address this at those multiple levels that I've talked about. We want to support our advocates more effectively but until we start embracing survivors at the various earliest points with empathy and compassion, who in their right mind would actually embrace the advocacy role? And until we can deliver a higher level of positive experience across the ways we're likely to be hampered there. But yet I continue to maintain hope, and that we can continue to work together to confront stigma and reduce its burden on the lung cancer outcomes that we hope to achieve. So I want to transition now to spend a bit of remaining time that I'll probably have to go through rather quickly, some of these slides, but to optimize our delivery of lung cancer screening in terms of reaching our rural communities. I'm very proud Coloradan at this point, but my view on the world used to look out on these kinds of things. And you may notice, for those fans of the Nuggets, a familiar, he used to wear a different color of jersey before he joined the Nuggets. But those are things that most people know about Kentucky, but also people know about Kentucky is it has a devastating burden of tobacco use. We are still at about just under 25% of adults use tobacco on a daily basis in Kentucky. I'm going to skip over the epidemiology, but trust me, it's rough and in terms of the incidence, whereas Colorado tends to mirror the national averages and sometimes even a little bit better. But the burden of lung cancer is also not distributed across states equally. You can see here that this is an image from JAMA from a few years back, showing the burden here in this deep red area of Appalachian Kentucky. And even within Appalachia, you can see this is in many ways out here to the east, the epicenter of lung cancer in the entire world occurs right here in Appalachian Kentucky, in terms of rates that are 50% higher than the national average, which is incredible. And yet there are new things that we can do about. And I think Kentucky is in many ways leading the effort to make some dramatic changes, particularly in the utility of lung cancer screening. That in many ways we're in a live action game of translational science for those researchers that is taking lung cancer screening into the communities. And we are way out here. We're looking at the T3 translation and using implementation science to understand the barriers and facilitators that influence successful implementation of effective interventions, particularly lung cancer screening. I think of lung cancer screening as in many ways parallel to the Corvette that is now being delivered in this year, and it just happens to be built in Bowling Green. We have a beautiful new technology with the low-dose CT scan, and it's all ready to go based on the fuel that we have, the data, the NLST, the Nelson trial, and the policy. We also have team members in terms of the lung cancer screening program team that serves as the manager and the pit crew. Primary care is our ignition switch to get this process going based on how it's structured. The patient or the participant is the driver in this situation. I'm using the analogy of really person-centered care, that they are at the heart of this experience, but indeed they are inexperienced. We have not screened this community before, and we need to figure out ways to reach them. And the course is also, rather than a very nice comfortable, flat oval. It is actually a rather new and bumpy road course that we have to figure out how to navigate in the future. So we're all set up and raring to go, but we have challenges that are facing our ability to get this disseminated effectively. You can see here, this is a slide that looked at uptake and the whopping changes in uptake of lung cancer screening following the policy changes in 2015. And of course, I'm being sarcastic with that whopping change, but yes, there was a slight increase, but there's so much more we can do in this space. You know, the good part of the story is that by using different indices, we are seeing an increase. But one of those increases that I like to highlight is in Kentucky. There are not many parameters where where Kentucky leads the country in a health parameter on a good way, or on a good way. But this is one of them where Kentucky has leveraged the opportunity to implement lung cancer screening and realized it more effectively than many other places in the country. And we think that's through our work on raising awareness of lung cancer screening in our communities, building tools to engage and prepare and manage patients participants throughout the lung cancer screening process, by working with our screening programs to educate them about how to deliver high quality lung cancer screening and develop the support systems they need to support the patients and participants through the process, by educating our primary care clinicians and our healthcare system about lung cancer screening, the benefits, the challenges, the harms, the full package of what the lung cancer screening process is like. And then, of course, working at a national level to monitor and provide feedback. And so our two fundamental principles have been a person-centered approach that understands who these individuals are we're trying to serve, and then engaging the community with our efforts, and community broadly defined as partnering with each of these entities to support their implementation. I'll talk about just a couple of strategies at the individual level and the community level, but the first comes with a fundamental understanding that I mentioned about these groups as in individuals that are somewhat distressed. I'm not sure why that distressed is not coming up there, but they're stigmatized. It's a fatalistic group that's been taught what we know about lung cancer screening is that it doesn't have a good outcome. They're somewhat skeptical in terms of their approach, you know, to new healthcare opportunities, that based on how we've not necessarily treated them in a very patient friendly way in the past. They're disengaged with their healthcare. These are not active decision makers or people who tend to be reaching out for more healthcare. They're usually in the situation of responding to concerns, and they're also heavily dispersed, meaning that they're distributed throughout the community and heavily located in rural areas that are a bit harder to reach with lung cancer screening. And Dr. Fenton mentioned earlier that another point that I also like to make is that we have CT scanners all over the country in rural and critical access hospitals. So it's not the technology that we lack access to, it's the skills to manage programs and operate programs that is vital, which is why so many of our efforts have been focused on engaging the community, engaging clinicians, training radiology and pulmonology practices in rural areas to operate lung cancer screening programs in an optimal way. In terms of community awareness, you know, what percentage of society knows what this machine is and what it's for? But if you put it in as the low-dose CT scanner in a different range, if you go out in the community, what percentage of the community, if you were to use the acronym LDCT or low-dose computed tomography, what percentage of the community would understand what that is, whether they were eligible or not? And we're still at essentially zero in public understanding, maybe a few percentage points, but essentially zero in terms of getting out our message with regard to what a low-dose CT is and who it can serve and benefit. The story of lung cancer screening implementation in Kentucky starts with our consortium partners. And we started offering programs to go to using the consortium as a foundation, going out and doing what we called the Lung Cancer Screening Roadshow. We engaged advocates, clinicians, and community members through these meetings in regions for a bidirectional sharing of cancer-related concerns, perspectives, and data. But when we did this, we had a platform that used local individuals combined with experts in the area to expand knowledge and awareness of lung cancer screening and that opportunity. I'm going to skip through this. And then we also developed a continuing education program where we go into sort of do a grand round style presentation. Is there anything novel about this? No, in no ways whatsoever is this all that exciting, but it was about getting the message out to the primary care community in order to make sure that they were aware of both the opportunity for lung cancer screening and understood the importance of shared decision making in the context of lung cancer screening, as it was a mandated part of the actual intervention portfolio on the platform. The other piece of community engagement came through the Kentucky Leads Collaborative, which focused on provider education on broad spectrum of lung cancer prevention and control and care, but also working directly with lung cancer screening programs to help them understand their responsibility in the community for advancing the cause of lung cancer screening. In terms of these provider education efforts, we included academic detailing, where we tried to actually touch every single primary care clinician across the state with a message about lung cancer screening, whether it be a 2-minute handoff a pamphlet to them, if that's what they would allow, or offering an hour-long continuing education program over lunch. We also did large group presentations. They're more like grand rounds, and developed an online training course and offered webinars over the course of several years in order to achieve, really perfuse the idea, the notion of lung cancer screening into Kentucky society and clinical society. We just quickly reached almost 3,000 clinicians across the state of Kentucky with the message. And it was important here that it's not just physicians and nurses, it was front office staff. In the process of trying to normalize lung cancer screening, we wanted to reach everybody that we could. We also worked with lung cancer screening programs to optimize the quality of the services, not just the technical aspects, but the person aspects of it in terms of engagement strategies, integrating tobacco treatment, using community outreach activities to normalize lung cancer screening in the community, to embrace the at-risk community in many ways. And then we would evaluate these programs through a system of auditing them and providing feedback, and then using a resource to help guide them with tools that they could actually implement in their practices, a combination of continuing education for every person who had a role on the lung cancer screening team. There was specific education for the radiologist, for the navigator, for the referring primary care clinicians. And we were able to implement this at 10 sites throughout Kentucky as part of the process of the Kentucky Leads Collaborative. So those are just a brief example of some of the community engaged activities and person-centered approaches that we tried to infuse in our efforts to expand access to lung cancer, high quality lung cancer screening in Kentucky through the delivery of tools, encouraging this unique approach that made sure people understand we are 50 or 60 years behind the implementation of mammography. We cannot take what we do in mammography to engage patients and just apply that to the lung cancer screening community and expect it to work. We want to take we may be able to use some of those things, but we have to start with a fundamental understanding of the community that we're trying to reach and start there with our engagement activities, with our uptake and patient support activities, as opposed to trying to borrow too much historically, because it's a different time. It's totally different time. And I go back to that point I made about, what percentage of individuals understand what a mammogram is versus a low-dose CT. These community engaged activities need to expand to clinicians to make sure we normalize lung cancer screening among clinicians, and then continue to provide tools and collaborative support for everyone in the whole process in order to achieve our most optimal outcomes. And I realize that I've started to talk increasingly fast to try to get everything in by the hour. I appreciate the opportunity to present to you, and hopefully there's some ideas that you can take away and reflect on with regard to Stigma. Stigma strategies to confront stigma in your organizations, as well as thinking about ways to reach the rural community with lung cancer screening. And have more comments and ideas about reaching the rural lung cancer community with different kinds of messages, but just didn't have time to go into those kinds of things today. So thank you very much. And if there's time for questions, I'm happy to hang out for a little bit past time.
Jamie, thank you so much. What a tremendous, high quality presentation with just a wealth of information. We are so appreciative. We're so lucky to have you in Colorado now. And, I really look at this as a call to action. Thank you. We don't really have time today for questions, but if you notice on the screen, for those of you participating in the Lung Cancer Screening Collaborative, that Jamie will be participating in our panel discussion next week. And so Dr. Tim Kennedy will be our moderator, but Jim Fenton, pulmonologist, Dr. Kyla Croft, family practice physician in Colorado, Linda Sample, healthcare consultant, and Jamie will be participating in that panel discussion where we're going to talk about just how do we make all this happen in lung cancer screening. So thank you so much, Jamie. Thank you to all who participated today. Remember, if you did ask a question and we didn't get to it, we will make sure that we get your question answered. And we'll forward the question to Jamie if needed, or some of us others might be able to assist with the answers. So I'm going to turn it back over to Christy now.